Good evening, everyone. My name is Shirley Yates, and I will be presenting on thoraco-lumbar spine degenerative disease. I have divided this actually into three parts, so hopefully next week I'll be presenting on lumbar back pain as well as principles of surgical management. So in my presentation, I'll be talking about, as I said before, thoraco-lumbar degenerative disease. I'll be focusing on the normal anatomy, the definition of the disease, epidemiology and anatomical changes, lumbar spinal stenosis, spondylolisthesis, and juxtafasciitis of the lumbar spine. So when we're looking at the anatomy of the thoracic and lumbar vertebrae, I put a different slides or different sections of it. The body of the lumbar vertebrae is actually larger and kidney-shaped versus the cervical, which is heart-shaped and bears two costal facets. In terms of the spinous process of the thoracic, it is longer and sharp and projects inferiorly, whilst the lumbar spinous process is short, blunt, and projects directly posteriorly. The vertebral foramen is circular in the thoracic vertebrae, just like, unlike the lumbar, which is triangular, like the cervical, 3 to 7 vertebrae, as Dr. Anthony would have described. The transverse processes of the thoracic spine bear facets for the ribs, except for floating ribs T11 and T12, while the lumbar transverse processes are thin and tapered. The superior facets of the lumbar vertebrae are directed posterior-medially or medially, while the inferior facets, however, are directed anterolaterally or laterally. The superior facets of the thoracic vertebrae are directed posteriorly, while the inferior is anteriorly. Lastly, the thoracic vertebrae allow for rotation and lateral flexion, which is limited by the ribs. Flexion and extension, however, is prevented, whilst the lumbar vertebrae allows for flexion and extension. Some lateral flexion, however, some lateral flexion and rotation is, however, prevented. So what is the definition of degenerative disc disease? So this disease encompasses a wide heterogeneous set of health conditions which can affect all musculoskeletal and nervous tissues along the spine. This progressive deterioration of the structures of the spine not related to acute trauma are frequently associated with pain syndromes, radiculopathy, spondylosis and spondylolisthesis, stenosis, fractures, tumors, and osteoporosis. Age, genetics, nutrition, and mechanical overload can all contribute to this degenerative process. This disease is linked to significant pain and disability, generating a major socioeconomic burden given its high global prevalence. Patients often present with pseudoradicular pain, mostly due to the degenerative processes involving these intervertebral discs, facet joints, and soft tissues. Oftentimes, it may be asymptomatic and the degenerative changes may be discovered incidentally. Pain is most reliably linked to either neurogenic pain, and that's due to the compromise of the neural spaces, usually due to spinal stenosis, which I will touch on later, but may involve other factors such as spondylolisthesis and synovial cysts, or mechanical pain, which may be provoked from muscles trying to compensate for the loss of spinal balance due to the degeneration, abnormal contact between the bone, as well as enlargement, flattening, and reactive sclerosis of opposing interspinal surfaces. The most common location for this is at L4 and L5. And what happens is you have a production of localized midline lumbar pain and tenderness on back extension that's usually relieved by flexion, local anesthetic injection, or partial excision of the involved spinous process. Or possibly you may have pain that's focal, due to focal excessive force on the spine itself, and that might be because of sclerosis or kyphosis. Now, as you see on the screen, I have listed a few clinical syndrome of symptoms related to degenerative changes of the intervertebral disc. So as I said before, you have fibrosis, you also have desiccation, narrowing of the disc space, diffuse bulging of the annulus beyond this space, extensive fissuring, that's where you have nummular annular tears, mucinous degeneration of the annulus, defects and sclerosis of the end plates, and osteophytes of the vertebral apophyses. It was also considered to encompass degenerative changes outside of the disc. So at least 266 million individuals worldwide suffer with this disorder. In Europe, it has a percent of 5.6, and to lesser Africa of 2.4. It usually affects persons of low to middle income countries. And additionally, these conditions, because of this disproportionate, the low to middle income countries experience it 4 times as many cases as the high income countries. Furthermore, global incidence rates reveal that 403 million people, or 5.5%, experience symptomatic disc degeneration. 103 million, or 1.41%, suffer from spinal stenosis, and 39 million, or 0.53%, are affected by spondylolisthesis each year. So different books would show you, well, basically they will describe the different changes, the anatomical changes, but I found something very simple where they divided it into ABCs of degenerative spine. A changes, sorry, excuse, So A changes discuss the degenerative process, usually that starts within the nucleus pulposus. You have B changes that discuss or includes the abnormalities that extend to the disc, the annulus fibrosus, the end plates, and the bone marrow of the adjacent vertebral bodies. And then you have C changes, and this is where you have the advanced degeneration that may eventually involve distant structures and lead to facet joint osteoarthritis, ligamentum flavum hypertrophy, and spinal canal stenosis. So A changes, as I said, the degenerative process that involves or starts with the nucleus pulposus. So the intervertebral disc structurally consists of fibrocartilaginous annulus fibrosus, encasing a gel-like matrix in the middle termed the nucleus pulposus. The interaction between these two extracellular components, that would be the proteoglycan and the type 2 collagen, imbues the nucleus pulposus matrix with hygroscopic properties, which is very important and crucial for the IVDs or intervertebral disc to be able to absorb the compressive shocks during movement. Any damage to the end plates due to these cyclic compressive loads marks the beginning of the cascade of degenerative disc disease. However, these same cells, or the NP cells, also produce MMP, or we know better known as matrix metalloproteinases, which degrade the NP ECM, or extracellular matrix. If the cellular microenvironment shifts, the IVD cells go into a catabolic state, and then they start degrading the NP matrix. B. This includes abnormalities that extend to the disc, the annulus fibrosus, end plates, and bone marrow of the adjacent vertebral bodies. So aging gradually increases the production of collagen, favoring collagen type 1 production over collagen type 2 production, which makes the IVD gradually more fibrous. The anatomical demarcation between the nucleus pulposus and the annulus fibrosus becomes significantly diminished as these two regions merge. Consequently, desiccation renders the nucleus pulposus more solid and granular, increasing the risk of cracks and injuries, not only to itself, but to adjacent structures as well. Additionally, senescent cells also contribute to the degenerative process by means of decreased anabolism and/or increased catabolic activity, as I explained earlier, reducing the actual tissue's ability to compensate for the net loss. So on this screen, can you all see my pointer by chance? No?
Yep.
Yes, no. Yeah, okay. So on this screen, I have on the left-hand side, you have an image showing the annular tears. You have the nucleus pulposus and the annulus fibrosus. Where you have the annular tears more to the medial aspect, you see that demarcation that we're talking about gets a bit muddled and mucky. Now you have different types of disc displacements and disc herniations that can happen because the nucleus pulposus decides to go through the annular tears. You can have diffuse disc displacement or focal herniations as shown on the screen here. Now, the disc herniations can happen in two planes. It can either happen in the axial plane or the sagittal plane. In the axial plane, it can be anterior, posterior, where you have central, paracentral, foraminal, and extraforaminal. But, and then in the sagittal plane, you can either have it as superior migration or inferior migration. Continuing on to B, we are now talking about the end plates. Now, the end plates play a very important and crucial role in the maintenance of the mechanical environment as well as the proper nutrition of the avascular disc. And damage to this structure is the hallmark of the degenerative disease. Now, you have at least 6 types. Type 1 is a normal end plate with no interruption. Type 2, however, indicates that you have a thin end plate without obvious breaks. Type 3 denotes an end plate showing focal defects without subchondral bone changes. Type 4 denotes an end plate showing focal defects signifies breaks involving less than 25% of the surface, usually associated with the adjacent bone marrow changes. Coming on to, and we have type 5, which refers to a large, up to 50% of end plate defects with associated bone marrow changes. And then lastly, we have type 6, which represents extensive end plate damage involving most of the entire end plate. End plate fractures lead to a sudden depressurization of the nucleus pulposus, so that middle part of the disc, and the migration of the nucleus pulposus material into the vertebral body itself. This elicits an inflammatory response and edema, which is detected on MRI, and we'll discuss images lower down, images and modality lower down, as bone marrow, or better known as modic changes. Very large end plate damages, like in type 6, with a large volume of migrated nucleus pulposus material usually indicates, forgive me if I pronounce this wrong, Schmall's nodules. So Schmall's nodules, as you can see on the top right image, you have this indentation or you have protrusion of the spinal disc soft tissue into the bony tissue itself. Now we'll focus on the C's, which looks at facet joints, ligamentum flavum, and spinal canal. Facet joint osteoarthritis may occur independently and be a source of symptoms on its own. It typically represents a secondary process, however, that is associated with disc degeneration and loss of disc space and height. The ligamentum flavum that we have here tends to become hypertrophic, and the degeneration of the elastic fibers and proliferation of type 2 collagen as we age. Type 2 collagen. Ligamentum flavum hypertrophy reduces the diameter here. The diameter of, up here, my bad, sorry. Ligamentum flavum hypertrophy reduces the diameter of the spinal canal posteriorly and is considered an important causative factor in the development of lumbar spinal stenosis. Now, lumbar spinal stenosis. This is basically where you have the narrowing of the bony canals through which the nerves and spinal cords normally pass. And there are many contributing factors. A few would be, so when you have a normally you have a congenital narrow spinal canal or short pedicle syndrome, which usually renders the patient or the person to be more susceptible to the following acquired changes. So they may have they may also have hypertrophy of the facets, ligamentum flavum abnormalities such as hypertrophy, which is very common, ossification, and infolding or buckling caused by loss of disc height. You may also have disc space changes such as disc bulging, herniation, osteoid formation, or collapse. Or may have malalignment of vertebral bodies, spondylolisthesis, arthrolisthesis, retrolisthesis, and alisthesis, forgive me, which again I will discuss further. Or we may just have abnormal intraspinal structures such as synovial or juxtafacet joint cysts, epidural lipoma, or epidural lipomatosis. Some other conditions that may be associated with lumbar spinal stenosis include achondroplasia, spasticity, ankylosing spondylitis, and acromegaly. So we have 3 types of lumbar spinal stenosis that affects the neural spaces, right? You have central canal stenosis, you have lateral recess stenosis, and you have foraminal stenosis. Central canal stenosis is where you have narrowing of the central canal. So that would be here itself. So we're looking at the entire canal. This side shows the normal anatomy and this side shows the pathological anatomy. So as you can see, you have central canal stenosis where you have the central canal isn't in its full diameter as compared to the left. When severe, it causes local compression of the nerve roots in the canal itself and or by exiting roots and chorda equina. It may be congenital, as I discussed before, as an anatomic variant, or in certain syndromes, like I said before. When there are symptoms, it's usually because the acquired stenosis is superimposed on congenital narrowing. Then we have lateral recess stenosis. That will be this one highlighted here. And this line that I'm drawing here will be very important later on that I'll discuss. So when there's hypertrophy of the SAF, that's in the back here, that would be the superior arterial facet, this one here. So when you have hypertrophy, if you look correctly, you can see this is normal and this is a bit bulging into the space itself. The nerve root that passes through here becomes compressed. So basically, think of a hose passing through a gutter or water passing through a narrow gutter. Oh, my bad, sorry. It affects right here. L4 and L5 is the most commonly affected area, and this stenosis is present to almost all central canal stenosis cases, right? So what I'm saying is that basically when you have central canal, because of the hypertrophy, as well as you can have the ligamentum flavum being so severely hypertrophied, it can actually affect the lateral recess area. Foraminal stenosis is where you have narrowing of the neural foramen. And I put it on here. So you have these openings, the series of openings on both sides of our spine. And it may be a result of foraminal disc protrusion or herniation, vertebral malalignment like spondylolisthesis and facet hypertrophy. And it can cause compression by upward displacement of the superior articular facet of the level below into the neural foramen. I just put this here so that we can actually compare the different ones looking at with an MRI. So we can see different grades. You have grade 1, grade 2, grade 3, and central, lateral, and foraminal stenosis. I'll just compare the extremities. So you have chorda, in grade 2, you have chorda equina and aggregation, but then in foraminal, you have moderate stenosis, at least 50%. So the clinical evaluation of lumbar stenosis. So what when we assess patients, we usually ask them the history, what's the cause of the pain, and then we would examine them neurologically. So when patients come in and we discover that they have stenosis, or we assume that it's stenosis, they would usually describe a type of radicular pain. And that's the pain that radiates from your back, say lower back, into your hip and down into your legs. You can also have neurogenic claudication in the lumbar area and then spinal myelopathy in thoracic area. And I will touch on neurogenic claudication later on. Patient may also have sagittal imbalance and scoliosis as a result of degenerative changes. And this can place focal stress on specific spine structures, which may be painful. The muscles in the back sometimes can compensate for the imbalance, and this can also be a point of pain and overuse from fatigue. You have discogenic pain, which many surgeons or authors query as controversial, and they may be less prevalent in the late stages of the disorder. It may contribute to musculoskeletal low back pain, this achy pain that most patients complain of, but the actual pain generators have not been specifically identified. And as I said, the history is very important of the clinical evaluation of lumbar spinal stenosis. The typical symptoms, as I said, is neurogenic claudication and sudden onset. One thing that we must remember, sudden onset of this excruciating pain is atypical for lumbar spinal stenosis. If the neurological exam is usually normal in at least 18% of the cases, so patients might be able to have normal muscle stretch reflexes and negative straight leg raising tests. But some findings in our examination of persons who have lumbar spinal stenosis would include weakness in the anterior tibialis and or extensor hallucis, absent or reduced ankle jerks and diminished knee jerks are very common, though this is also prevalent in older persons or the age population. And then forward flexion at the waist with ambulation is often observed. Pain may be reproduced by lumbar extension, so having the patient bend backwards. So leaning forward gives you some relief, and leaning backward actually makes it worse. An important part of the exam to rule out is things that mimic lumbar spinal disease. So like sacroiliititis or trochanteric bursitis, which way you would have tenderness over the sacroiliac or hip joints and vascular claudication. These different mimickers will usually not respond to the same treatment for lumbar spinal stenosis. So, as I said before, lumbar spinal stenosis characteristically, forgive me this, presents with neurogenic claudication or pseudoclaudication. It's thought to arise from ischemia of the lumbosacral nerve roots as a result of increased metabolic demand from exercise together with vascular compromise of the nerve roots due to pressure from surrounding structures. Neurogenic claudication, or NC for short, is only moderately sensitive, but it is highly specific for spinal stenosis. Pain actually might not be the major complaint that patients come in with. They would describe paresthesias or lower extremity weakness with walking. Some may also complain of muscle cramping, especially in the calf area. In contrast, however, to a herniated lumbar disc, which usually produces acute severe nerve compression. The characteristics of NC are usually, as you can see on the screen, unilateral or bilateral buttock pain, hip, thigh, or leg discomfort that is precipitated by standing or walking, or painful burning paresthesias of the lower extremities are also described. So as I mentioned a few earlier, you have different differential diagnosis for lumbar spinal stenosis. They include vascular insufficiency, which we all know as vascular claudication or intermittent claudication, that like what we see in lower limb people with lower limb pathologies, particular persons with forgive me, issues with the circulation in the lower leg. You have hip disease, as I mentioned, so trochanteric bursitis, radiculopathies due to lumbar herniated disc. You have facet joint pain. You also have something called Baastrup's syndrome, which is also arthrosis interspinosa. And that's basically where you have the contact of the adjacent spinous processes, basically touching or kissing, as we say, with enlargement and flattening and reactive sclerosis of the opposite interspinous surfaces. You can also have intraspinal tumor, maybe a differential diagnosis. A type 1 spinal AVM that Dr. Lavelle will touch on in a couple of weeks. Then you can also have diabetic neuritis, musculoskeletal pain, and inguinal hernias as well can contribute to a lumbar spinal stenosis picture. So when we're looking at imaging, we know our three main images that we offer patients are X-rays, CTs, and MRIs. So lumbar spine X-rays would only demonstrate bony abnormalities, such as the spondylolisthesis, spondylosis, congenital narrowing of the spinal canal, and they are helpful for assessing existing fusion hardware, like a couple of patients that we had on the ward when we have put in the metal to fuse their lumbar bodies. Lateral flexion extension X-rays are useful for demonstrating dynamic instability, like in mobile spondylolisthesis. Standing scoliosis X-ray is important to help the surgeons determine the management of future fusions. Now, when the radiographer or radiologist is examining the CT for lumbar spinal stenosis, they have three ranges: average, lower limits of normal or severe lumbar stenosis. And you look at on the other slide, I have the actual measurements, but it's not a CT, so I use this one. This line that I'm drawing here would show you the AP diameter. And if you have an average or normal, it should be 22 to 25 millimeters. The lower limit of normal would be 15, and then severe lumbar stenosis would be if it's less. So this way, less than 11 millimeters. CT scans, as I mentioned briefly, are more sensitive and specific for the assessment of lumbar spinal stenosis. An enhanced CT excels in demonstrating bony anatomy and classification of structures such as the posterior longitudinal ligament, but it's sadly too insensitive to be relied upon for detecting spinal stenosis. It is best for the past fractures, bony fusion, and other spontaneous or iatrogenic fractures. The CT myelogram scan sensitivity for the canal stenosis is very close to that of an MRI, but is very poor for foraminal stenosis, but is also acceptable for persons who have contraindications to MRI. So that would be persons who have a non-MRI compatible pacemaker, or persons that have fusion hardware that would distort the MRI images. So as I show here, so the different measurements, right? So normal lumbar spine measurements on a CT. So the AP diameter, which would be number 3 here, should be less than or greater than or equal to 11.5 millimeters. The IPD should be greater than or equal to 16 millimeters. The canal cross-section area greater than or equal to 1.45 centimeters. The ligamentum flavum thickness should be less than or equal to 4.5 millimeters. And the height of the lateral recess, which should be here, number 1, should be greater than or equal to 3 millimeters. So MRI. So unenhanced lumbar MRI is a diagnostic test of choice. It shows impingement on neural structures and loss of CSF signal on T2 weighted in the central canal. It also shows lateral recess stenosis, foraminal stenosis, as well as juxtafacet cysts and increased fluid in the facet joint. However, MRI is very poor for visualizing bone and often needs to be complemented with additional X-rays and CTs, particularly for surgical planning. So the possible findings you would get in lumbar spinal stenosis on an MRI would be the narrowed canal, may assume a deltoid, aka tricuspid space. Then you have a redundant nerve root of the chordae equina. And then you can also have narrowing of the neural foramina. So in terms of management or treatment of lumbar spinal stenosis, this first part would only focus on the conservative management. So we usually prescribe patients some drugs, and NSAIDs are the drug of choice. Acetaminophen may also be effective. At least 6 weeks or more of physical therapy. Most patients do well with brace therapy, so an LSO may be attempted. And those who have persistent pain, we look at epidural steroid injections, facet blocks, and trigger point injections or sacroiliac joint injections. The epidural steroid injections might actually provide temporary relief. Sometimes it goes from days and weeks at most. What I will mention in part 3 is the need for surgical intervention, and it is usually undertaken when symptoms become so severe in spite of the conservative management. So we don't ever jump straight into surgical management for patients when they come to clinic. We always offer the 3 to 4 options above first. The goal of the surgery, as we always explain to patients, are relief, some pain relief, halting progression of the symptoms, and possibly reversal of some existing neurological deficit. Spondylolisthesis. Spondylolisthesis is basically when you have displacement or subluxation of one vertebral body on another in any direction. The most commonly, the superior vertebral body is anterior, as shown in the picture on the far right and the far left, anterior to the inferior one. and that's sometimes called anterolisthesis. Now, when the superior vertebral body is posterior, it's sometimes called retrolisthesis, and then you have ollisthesis, ollisthesis, sorry, is used to describe when you have the lateral displacement of one vertebral body on another. Spondylolisthesis is most common at the L5 on S1, and next most common is L1, L5. If the listhesis does not cause nerve root compression, it tends to involve the nerve exiting below, as shown on the far right, below the pedicle of the anteriorly subluxed superior vertebrae. So what that means basically is if you have an L4, an L5 spondylolisthesis causing nerve compression, it will generally involve the L4 nerve root or the L4 root. This is best seen on a T2 sagittal MRI through the neuroforamen. The compression is usually due to the upward displacement. Well, so the upward displacement of the superior facet. Sorry, something's wrong with my screen. Y'all can see my screen? Hello?
Yeah, we can see the presentation. So we've seen the X-rays. You have a pointer?
Yeah.
So yeah, we can see the pointer there. So you can use the pointer and show the exiting route in the foramen there.
Yeah.
Yeah.
So this would be the exiting route here. Well, if y'all can see it, I'll trust because it's not really doing much on mine. It's pretty slow. And yeah, so the upward displacement of the superior articular facet of the level below, together with the disc material, and symptoms usually resemble the neurogenic claudication, although you may have true radiculopathy that might occur. There's also some contribution from fibrous inflammatory tissue in the non-union, So we usually use, or from what the text I use, the Meridian grading system or classification. And this is usually in the sagittal plane, and it's sagittal plane. This classification in the sagittal plane is used for grading the grades of severity of slip. So you have grade 1 to 4, and then you have spondyloptosis. Grade 1 is less than 25%, grade 2, 25 to 50, grade 3, 50 to 75, grade 4, 75 to complete, and then spondyloptosis of greater than 100%. So there's the different ones, grade 1, grade 2, grade 3, grade 4, and grade 5. There are other grading or classification systems. So you have the tailored method, and this method describes the degree of slippage as a percentage of the anterior posterior diameter of the top of the first sacral or fifth lumbar vertebrae. So that percentage of slip would be equal to the displacement of the L5 on S1. Let me point it here, sorry. L5 on S1 width of S1 times 100. The result is an exact percentage of the slip. Then we have the Wilks classification, and this separates spondylolisthesis into 5 distinct categories based on etiology. So congenital or dysplastic, isthmic, degenerative, traumatic, and pathologic. Then you have the Marchetti and Bartolozzi, if I say that correctly, sought to improve on the Wilks classification, so the one I mentioned before, because of the isthmic group. So they combine a mixture of etiologies with each with a different natural history. Therefore, created a new classification system that featured a developmental type and recognized the Wilks subtype 2 of the group. Then we have the Spinal Deformity Study Group, or SDSG classification, which was developed as increasing research arose demonstrating the significance of sacropelvic morphology in the evaluation of treatment of L5 to S1 spondylolisthesis. So we have different types of spondylolisthesis. So as you can see on the screen, this is a normal anatomy of the lumbar vertebrae. Then you have the congenital or type 1, where you have dysplastic, as I said, dysplastic or congenital, and that's where you have the upper sacrum arch or arch of L5 permits the spondylolisthesis. There's no past effect at all. Some of these may progress to type 2 or type 3. Then you have type 2, which is isthmic spondylolisthesis or spondylosis, which is a failure of the neural arch as a result as a defect, in the pars inticularis. Then you have type 2B. And this one is where you have an elongated but intact pars, possibly due to repetitive fractures and healing. And then you have type C, where you have acute fractures in the pars. Type 3 is definitely degenerative due to long-standing intersegmental instability. So this usually happens at L4 and L5. You don't have a break in the pars, but you don't have a break in the pars. Interestingly, this was found in more in 5.8% of men and more in women at 9.1%. That was interesting for me. Then you have type 4, which is traumatic due to fractures, usually in areas other than the pars, and then 5, which is pathological. So that's where you have generalized or local bone disease, such as osteogenesis imperfecta. The treatment for spondylolisthesis is very similar to how we would conservatively manage a patient of lumbar spinal stenosis. So medication, physical therapy, whatnot. Now we have juxtafacet cysts of the lumbar spine. So a juxtafacet cyst includes both a synovial cyst and a ganglion cyst. So one basically has a synovial lining membrane and one lacks the synovial lining. That lies adjacent to a spinal facet joint or arising from the ligamentum flavum. They occur primarily in the lumbar spine, although they can be seen in the thoracic and cervical as well. The cause or etiology is unknown, and what they're postulating is that it might be due to increased motion in the cyst formation, and you will have trauma in the formation of it might be thought of as well. Now, the cyst wall are composed of a fibrous connective tissue, and there are usually no signs of infection or inflammation. And most patients with severe spondylosis and facet joint degeneration have these cysts in there when they come for imaging. They may be bilateral, and pain is the most common symptom, and it's usually radicular. Some of these cysts actually can contribute to canal stenosis and can produce neurogenic claudication or on occasion Corday-Quiner syndrome. The symptoms that patients will talk about with juxtafacet cysts may be more intermittent in nature than with firm compressive lesions like the herniated lumbar disc. When you have a sudden exacerbation of pain, it may be due to hemorrhage within the cyst, and actually most of them are asymptomatic. Now, why is this important? It's important because it helps the surgeon preoperatively work up the patient as the approach differs slightly from that for someone who has a herniated lumbar disc. In terms of imaging, we would use a myelography or CT scan, and the myelography would show posterior lateral filling defect, often with a round extradural appearance. The CT scan would show a low-density epidural cystic lesion, typically with a posterior lateral juxta-articular location. Some of them or most of them have a calcified ring, some have gas within them, and you may also have erosion of bony lamina seen. Now, the MRI would show variable findings. The unenhanced signal characteristics of non-hemorrhagic JVC may be very similar to CSF, and hemorrhagic JVCs are very hyperintense. The MRI usually misses the bony erosion that you would see on a CT. So this just shows an MRI through the L4, L5 facet joint, and you have a left-sided juxtafacet cyst. Now, inside here, you have some fluid, and it might suggest some surrounding fluid, and it might suggest some degeneration that may be occurring. Now, in terms of treatment, cysts may resolve spontaneously. However, they are prone to reoccurrence. Intervention is indicated for persistent symptoms. Cyst aspiration or facet injection with steroids has been described and is usually definitive treatment. And my next presentation, I would focus next week on lumbar back pain. So we'll talk about the nomenclature for this pathology and the clinical terms, the assessments, so acute versus chronic, and how we manage them, what we would find on physical examination, what we would deem as red flags in the history of physical exam, the radiographic evaluation, for low back pain, some psychosocial factors, and the conservative treatment for lumbar back pain. Thank you.